Hello, everyone. My name is Eunkyung. I'm a PhD student at UC Irvine. I'm excited to present our work on supporting clinician planning for discontinuation of psychiatric drugs. Growing adoption of electronic medical records has led to broader interest in clinical decision support tools. Clinical decision support tools can assist providers in many aspects, such as medication prescriptions or diagnosis of a disease. However, current tools often lack support for longitudinal planning, which is required for repetitive visits and multiple rounds of treatment. Supporting longitudinal planning is challenging as it requires frequent adaptations of treatment plans. The socio-technical context of healthcare involving multiple stakeholders, such as different types of healthcare providers, decision makers, health insurers, and pharmacies, make designing tools for longitudinal planning even more complex. Technology has a potential in providing informational and logistical support to help generate longitudinal care plans. Our area of focus is clinician planning for discontinuation of antidepressants, which often involves withdrawal symptoms lasting for months. To prevent withdrawal symptoms, gradual discontinuation over months, called a taper rather than abrupt cessation, is increasingly recommended by clinical organizations. Tapering antidepressants often requires iterative revision of the schedule to adapt to the patient's reactions and may involve non-standard prescriptions. However, these revisions require buy-in from stakeholders such as pharmacies and insurance companies. In addition, there is a lack of evidence-based guidelines on how to gradually discontinue antidepressants to mitigate withdrawal symptoms. Providers thus devise protocols based on their clinical intuition and often struggle if lacking experience. To understand how technology can better support longitudinal clinician planning, we designed and evaluated a clinical decision support tool for tapering antidepressants. In total, we interviewed 12 unique providers, a mix of psychiatrists and primary care providers across 3 sessions. AT Planner scaffolds the taper planning process by projecting tentative schedules which providers can flexibly adjust to fit their clinical regimens and automatically creates notes for sharing with pharmacies and patients. Let's watch a short video to walk you through the system.
AT Planner scaffolds the taper planning process by allowing providers to select from different options of available dosages for each drug and formulation with a visual interface. After setting the current and the next dosage, providers can choose the projection mode, duration of each interval, and goal dosage. Based on providers' input, AT Planner populates a tentative schedule projecting future prescriptions to scaffold taper planning. Providers can flexibly adjust the taper plans to fit their regimens by clicking on any interval in the table and change the type of medication, next dosage, projection mode, and length of intervals. When the changes are submitted, AT Planner repopulates the selected and the following rows with updated doses under the changed conditions.
Through a feedback study with AT Planner, we found that providers' taper planning practices were under interpersonal and infrastructural constraints. For the full findings, please see our paper. When planning tapers, patients' financial circumstances were an important consideration for providers. General practitioner 4 worked for underserved populations, oftentimes without health insurance. When tapering such patients, he would go for filling the fewest prescriptions rather than using the best tapering strategies. He said, "I usually try to work with what they've got. I would get them to break a tablet in half for a couple of weeks, and then get them to take one every other day." Therefore, he wished that AT Planner could suggest different combinations of pills to get a certain dose so that he could select from them in light of the constraints. Providers described that pharmacies and insurance companies also had particular volumes of prescriptions that they preferred prescribing, such as 90 days. Psychiatrist 3 said Here, it came up with 72 pills because of the next appointment. But they're gonna think that's odd. I may get a message in the evening asking to confirm if I only wanted 72 pills. So I would never prescribe that. Therefore, he perceived that AT planners' use of non-standard schedules may conflict with pharmacies' infrastructural needs. Providers often developed workarounds for the constraints of pharmacies and insurance companies. They sometimes sent pharmacies prescriptions that did not match with what they actually wanted patients to do. For example, if psychiatrist one knew that the patient's health plan would push for a 90-day supply, he would prescribe 90 pills of the lowest available dose and tell patients to take 3 tablets daily for a month. He therefore wished that AT planners supported greater flexibility in choosing pill strengths. Through this study, we found that providers played a significant role in balancing various influencing constraints. We posit that providers are more likely to experience challenges in balancing socio-technical factors in longitudinal care planning than in one-time clinical decision-making contexts, as it often involved non-standard treatment plans and required iterative adjustment. Providers' workarounds mainly occur when the socio-technical contexts are not considered in the design of clinical systems. In our study, we suspect that the lack of clinical guidelines around tapering antidepressants is likely to have led providers to seek out loopholes in EMR systems because the pharmacies and insurance companies lacked policies and protocols that aligned with the care regimens required for tapering as a result. We suggest the value of flexibility in clinical decision support tools. Allowing some loopholes in such tools can help providers navigate infrastructural barriers, particularly around longitudinal planning and a lack of standardized guidelines. In the context of tapering antidepressants, having the flexibility would help accommodate providers' needs in administering non-standard regimens and iteratively adjusting the plans, which would also be valuable in other domains requiring longitudinal care planning, such as infertility and irritable bowel syndrome. Allowing for flexibility would also be valuable for other domains involving complex health concerns that lack standardized guidelines, such as rare diseases or migraines. Thank you so much for listening.